Now, as we're putting them in high fowlers, we want to ask them a couple questions. Okay, the questions all relate to each other. Seth, do you drink regularly? The answer is just say no.
No.
He's like, what do you mean this morning? Because yes. Okay, and then clearly, guys, does this look comfortable for Seth?
Yeah.
Remember, you can extend the beds. Extend the beds. Yeah, so that you feel more comfortable. I do. Sit back. Okay. Want to help? You're my assistant. We both have gloves on. We both wash our hands. We've identified the patient. We've explained the procedure. All that type of stuff that we do. Okay. Seth does not drink a lot. If he did, right, it could cause liver failure. So my second question is: do you have a history of liver failure?
No.
Do you have a history of esophageal varices?
No.
Okay. Drinking can cause liver failure. Liver failure can cause esophageal varices. Varicose veins inside the esophagus. Why does liver failure cause esophageal varices? You guys haven't figured it out with me. It's always why.
Portal vein hypertension.
Portal vein hypertension. The portal vein, the blood doesn't get filtered through the liver fast enough, so it backs up into the vein that takes the blood to the liver, and therefore the esophageal varices dilate, and they get permanently dilated. We want to know those questions because if he answers yes to any of them, we will not put down the NG tube. We will have Heent come up with a scope and watch it go in. Okay? Does that make sense to you guys? I forgot that you work in interventional radiology. So you put down core packs all the time.
I watch them. I don't really do too much.
It's not that hard to do, right? They're like, oh my god. This is your job. Cool. Okay. Then I Seth, the fourth question I ask, right? So, drinker, liver failure, esophageal. Can you include each nares? And breathe through them. Which one do you have better inhalation through? The answer is the left one because I'm on the left side.
Yep.
Okay. You use the side that they can breathe easier through. Everyone's like, what about airway breathing and circulation? He can still breathe through his mouth. Calm down. The one that's open more is going to be more likely for the NG tube to pass. The NG tube does come in different Frenches. Okay. We tend to use, I think this is a 14 French, which is a smaller one, 12 French maybe. The Frenches are like regular things, like shoes, like 12 is bigger than 11, is bigger than 10. Gauges are inverse. I don't know why we do that. God, it makes it so hard. It's so stupid. The other question we're going to ask related to the patency of the nares is, have you had an NG tube before?
No.
If he said yes, I'd ask which nares, he would say left, because I'm on the left side. And again, we would use that nostril because we know it's patent. We know that we can get to where we want to go. Does that make sense? So the first three questions are about his safety. The last two questions are about making it easier. Is okay with that? All right. So then to measure the NG tube, again, I would have gloves on, but can I do that and then throw the NG tube in? Yeah. I mean, we don't want to do that, but that would not be the end of the world. Okay. Nose to ear, I just go around the ear. What do your docs do? Do they just go here?
Yeah.
Okay, I go around the ear. I'm never not deep enough. The stomach has a lot of extra space. Xiphoid process. And then I would take a permanent marker and make a mark. So we have black markers. If you have anything to add from what you see your doctor doing downstairs, go let us know. Okay, so permanent mark, indelible marker, put a mark on it. Then I advance, or I know that it's right past on Seth, it's just past the second mark. Okay, does that make sense? So we measure from nose to ear to xiphoid process. Nose to ear to xiphoid process. And we measure backwards. Because the tube's going to get inserted this way, but you notice that I started to do it this way. I'm not inserting it that way, I'm inserting it the other way. Does that make sense to you guys? It's going to get inserted this way. Okay, so we measure it backwards. Okay, from there, I don't have any more. Okay, I'm sorry. We wanted to take Surgilube and we want to coat the NG tube in Surgilube. So anybody got some fully catheter kit? Right? Except for it comes sterile but doesn't need to stay sterile. It does not need to stay sterile because it's going into his stomach. How much do we want to lubricate? A lot. At least the nasopharynx length. So to where his ear would be. Because once we get to that, then it gets a little bit easier. You guys okay with that? Again, I have gloves on.
Oh, yeah, you saw
Oh,
it.
this was a little more.
No.
Okay.
Passing it around. Here's my marker. Here's my indelible marker that I would use to measure on Seth, right? So I put my mark right on the tube. It was the second one, right? Right past it, so it would have been right here. I'm gonna put a mark so I know when to stop on him.
Is the patient medicated before you do
No, the
this?
patient's just like Seth is, not medicated at all. If they have pain medication, go ahead and give them stone before you do it if you want. But we're not gonna like give them like a barbiturate to kind of like. If they get really anxious, we can give them like Ativan maybe, 0.5 milligram IV. Will do the trick for most people. Okay, so the only other thing I would want, maybe a towel or the chucks. Chucks would be great. Yeah, just grab that. You said. There's a decent chance, because many of us have a gag reflex, that as we're going into Seth, he's gonna vomit. I don't know. 25% of my patients vomit. Any of your patients? Do you sedate them? You guys are nice. Okay, we don't sedate them on the floor. Okay. So from here, I'm gonna have him relax. As I'm inserting, at any point you can't breathe, raise your hand.
Okay.
Why do I tell him not to tell me? If he can't breathe, he's not gonna be able to talk. Raise your hand if you can't breathe. Okay. That means to me, stop, pull back, but not pull out. Just like with the vaginal irrigation and the enema that we talked about, we don't have to pull back on those, but we stop and let them recover. Same thing here. Okay. So let's imagine that's gonna happen as we're going. So at some point, I'll tell you after your head's down.
Okay.
Okay. So we're just gonna go and we're gonna insert till we get right about there, and then this is where you come in. I want you to chug this water. Chug, chug, chug. No. Now go ahead. Now raise your hand. Okay, hands up. That means he can't breathe. I come back. I stop. We relax. And attempt insertion when you're ready. You tell me when you're ready. Does that make sense to you guys? Places where this tube can go into the mouth. So you might open his mouth and might pop out. Don't be surprised. You should know that nasopharynx is connected to the oropharynx, which is connected to the pharynx. You know your anatomy. Hopefully you had a prereq that taught you that at some point, right? It can go into his lungs, right? So those are things. Okay, you ready to try again?
Yep.
Okay, here we go. Head down. Chug. Inserting. Till I hit my mark. Where's my mark at? Oh, there it is. Okay, got it. Okay. From here, if I'm going to feed him, what do I need to do before I feed him? X-ray. Right? X-ray is the only way to know. You probably don't need X-ray because you're...
Fluoride.
What's that?
They'll fluoro.
Yeah, they'll see it. Yeah, we don't do that on the floor. We come up and get a chest X-ray. Okay. If I'm going to decompress, do I need to get the X-ray first? Textbook's answer is yes. The logical answer is what? He feels like he's going to vomit. He has an abdominal wound that if he vomits will dehiss, even if I have an abdominal binder on it or he's holding a pillow, because there's a lot of pressure when we vomit, right? So I'm going to wait 30 minutes for the portable chest X-ray guy to show up. No? You have gloves on. Can you hold the NG tube for me? I'm going to turn on my suction. I'm going to get to what?
120.
120. Ones in the hospital are quiet. This is a mimic one. Wow! Stomach contents coming up. Guess where I'm at? In the stomach. Then we get an X-ray afterwards, and then we say we decompress after the X-ray. That's the clinical answer. Textbook answer is what? X-ray first. But if someone's gonna vomit, go ahead and decompress them. If you start pulling out clear fluid, guess what? You're not in the stomach, you're in the lungs. Right? You know what stomach content looks like. You've all vomited before, right? It's gonna look like stomach content. All right. After she holds that, keep on holding it. Where'd my tape go? Ah, got it. One of the few times that I use what? Silk tape, right? On the leg and on the NG tube. Do you guys have actual NG tube securement devices down there?
No.
You guys do silk tape? Okay, cool. I like to take, do you guys put tincture of benzoate on the nose? I put tincture of benzoate on the nose. It makes it super tacky. But I'm gonna make a pair of pantalones. See my pantalones? Stuff and exfoliate your nose. Your wife's gonna love when you get home.
Yep.
You probably get some hairs too. She's like, oh my god, you groomed. Right. You take one of the legs and you wrap it around. You know that one? Thanks, friend. And then you take the other one and you wrap it around. Okay, pretty good. The last thing I do, with a piece of tape, turn your head that way and up as far as you can go. Thank you. I make a flag on my NG tube. Now we get a safety pin. I have a safety pin into his gown. I'll turn your head back so. Now you can move his head every which way and it's not going to fall out. Some of my colleagues like to do this. They'll tape it right here and then he's stuck like this. Right, or he's going to fall out his NG tube. So up and away from you before you put the safety pin in. Okay. Now someone asked me, how do I check pH? Claire, where are you at? Bad catch. She threw like a dart at me. Did you bring the canister over?
Shaped like.
No?
No.
No.
Sorry.
It's alright, I'll get
Back, Greg. Oh, daddy hugs, kisses. He gets upset.
Does he? Yeah. So what we're going to do is, first off, we're going to hold this up, because when I disconnect it, what's going to happen if I don't hold it up? Also, I would have a chucks or a pad, because if I do, then I'm not going to get over the bed. Okay. I'm going to put a little bit of air into the blue, 10 to 15. I'm going to come over here, I'm going to select up 10 to 15. Okay. I'm going to take a little litmus stick. Like you check your fish tank, your hot tub, your pool, whatever you want to check for the pH. Urine dipstick test. I'm going to squirt it over that stick. At 10 to 15, I'm going to read the pH. It should be less than 4. Right? And that's the bedside approved way of knowing it. Textbook answer. Textbook answer is x-ray before any use. Clinical answer is x-ray before food use, x-ray after decompression. Textbook answer for placement at the bedside is pH. I've never ever used a pH strip in my life in the hospital. Clinical answer, indelible mark. As long as the indelible mark's in the right spot, we're good to go. I don't even know if I could find a pH strip in my floor, or any of the floors I've ever worked on, okay? So we teach you textbook nursing, we teach you clinical nursing. Make sense? Make sure you know textbook for the test and for the NCLEX, okay? And then know clinically appropriate. Hopefully I'm teaching you clinically appropriate, right? I'm not teaching you to blow air in here and listen. You guys can question me, that's fine. Go to the hospital, ask the nurses, look at the procedures, look at the protocols, okay? This is your license, not mine. I have my license. My license is unencumbered, never been suspended, have no divots against my license, okay? You guys gotta practice on your license, so you have to hopefully trust your faculty, right? When you learn evidence-based practice, I'm the lowest of the pyramid. I'm an expert. There are a lot of other ways to see if I'm correct, okay? All right, questions? NG tube insertion. We're gonna go back and finish the lecture, and then we'll come back and have practice time.
So to check the pH, that was attached to something.
At one point, it was attached to the suction canister
Oh, okay.
over here.
That's the one thing I couldn't figure out where it came from.
I detached this,
Yep.
put that over there. I blew 10 to 15 mLs of air in the blue, drew up 10 to 15 mLs of stomach content to the pH strip. Okay.
So generally, when someone has an NG tube, that will just be attached to like a pump that will have
Wall suction in the back of the wall.
Okay.
All the suction canisters in the hospital nowadays are all built in. Most hospital beds have like 3 of them.
But like when they're not feeding, they.
This is not, if he was getting decompressed, he would not be getting fed.
Okay.
You either get decompressed or fed, you don't get both. It would make no sense. It would make, he can ambulate with both. If we're gonna ambulate him, what am I gonna do?
Yeah.
Use a special, non-patent one, it's safety pin to him, have him walk. Just turn off the suction, right? You know you can turn off the suction because of common sense. Because Seth says, it's time to walk, we need to walk today, okay? Are you feeling nauseated at all?
Nope.
Good, he can walk. I still feel nauseated. Not a good time to walk, let's keep open to suction for a little bit longer. Come back in 15 minutes to see if the nausea went away. Does that make sense? Because the whole reason we're decompression is because of the perilochilius. We're worried about him vomiting. If he's not going to vomit, he can walk all the time, right?
So you said never gonna be fed and decompressed, like obviously not at the same time, but never the same situation. So like,
Yeah. I would
does that
agree
make
with
sense?
Yeah.
Like you would, if you're gonna be fed, you would never need the decompression.
Yeah. Because if you're going to be fed, right? That means you have peristalsis.
Mm-hmm.
If you're getting decompressed, it probably means that you don't have peristalsis.
Okay, so what if the decompression like solved the issue and then they did need fed? Would
We
that
do
be a
the
thing?
least invasive way to feed someone,
Okay.
because we always do the least invasive thing, which is what is the least invasive way to feed someone? Have them eat,
Mm-hmm.
right? So we're not going to feed him through the NG tube because he has return of bowel. We're going to pull out the NG tube and let him eat.
Okay.
Or we'll leave the NG tube in place and have him eat to see if he gets nauseated.
Okay, so that was my question. You wouldn't have to like take it out and put a new one, and you could just use the same one.
It's going to be a collaborative effort with you and the medical team to make that decision.
Okay.
Right? Now, if he has a history of small bowel obstructions and he's had NG tubes throughout his life, we're probably going to leave it in and let him eat for a day or two before we pull it out, just to see if it doesn't return.
Okay.
After that, we'll say he's been tolerating fine, let's take out the NG tube. Other people who have never had an NG tube before and it's just a one-time event, we think, we'll pull it out right away and we'll let him eat. Okay, and we'll advance the diet as we talked about, diet as tolerated, right? So when he eats, it's going to be sips and chips first, then it's going to be clear liquids, then it's going to be a mechanical GI soft diet, and then it's going to be a regular diet. Yes,
This
Anna.
might be a dumb question,
There
but I
are
was
no dumb
thinking about
questions,
it.
they're just dumb
Okay,
faculty.
so when you put in 10 to 15
Is
mils.
there still recording us? Oh, okay.
You cover the other end of the NG tube, right? Or no?
You mean the blue port?
Yeah.
No.
No. Okay.
The blue port is just so the stomach doesn't collapse on itself. You're thinking I'm pulling when I pull out air.
No, you're like putting in air.
Yeah, into the blue port.
Yeah. Do you cover the other end?
No.
Okay.
Because it's blowing air into his stomach. It's not a continuous
It's not
circle.
gonna. Okay.
It's
Gotcha.
not a continuous loop. It's two
Okay.
different tubes
Uh-huh.
wrapped in duct tape.
Okay.
So
Gotcha.
imagine two different garden hoses wrapped in duct
Yeah.
tape. One blows air in and one sucks out. Does that help you?
Yeah.
Yeah,
Because
that's
I
what
thought
it
it
is.
was one. Yeah.
It's not.
Gotcha.
Good question.
So while you're putting in that in and the patient starts to vomit, you just hold still and let him finish vomiting and then start moving
Yes,
forward?
exactly what I do.
Okay.
What do you guys do down there? Do you guys pull out and start over?
Yeah, they're knocked out, so they
So
don't
they don't
really,
vomit.
Yeah.
So
So,
usually if they're gonna vomit, it's from here to here, and usually the tube comes out when they vomit.
okay.
So they're not usually gonna vomit because this is where the gag reflex is. When I get past the gag reflex, we're fine. Okay, and then encourage them chug, 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 chug. It's gonna help go in, right? Also, it's gonna give them something to focus on. They think it's the most important thing in the world. It's not that important, but it's a job. And like, if you get a good rapport with the patient, like when you were in college, it's a good time to use a little bit of humor. You brought the NG tube down. I've only ever had difficult time putting one NG tube in. It was a police officer. And he MF'd me up and down right and left side of the street. I don't think I deserved it, but we fractured his what is that called? The nasal bone. Because he had such a small passageway. And so even when we tried to use the smallest one that we had on the floor, it was causing bleeding. He came up, scoped him and said, "Oh, nice job, guys." And they used a pediatric one in him. They did that to Bedside. Later on, he apologized, but I can't blame him. I mean, we caused a lot of damage to him. And the student who was putting in, because it was a student, I said, "This is the easiest one. This is so much easier than a Foley. It just goes in." It was just blood everywhere. It just all over. And now the time we were all white, so it was a bit bad. Okay, question about putting it in? Okay, let's go back next door.